Well, thank you all for having me here. I'm a pediatric neuropsychologist here at Hasbro Children's Hospital, and I've had the pleasure to work with Dr. Klinga here with some of her patients. And I'm going to talk on the practical side. What is it like to test children and work with children? I'm going to talk briefly on some of the domains that we think about testing with kids for these conditions, ways we can assess it, and different examples of how other research has been used. You know, what Dr. Schaumann just presented is a really nice, very brief bedside model. I'm going to talk about some of the other stages, both computerized batteries and more traditional neuropsych batteries as well. And then talk about the issues when we talk about trying to extend downward into children, particularly children under 10, what happens with developmental issues for those younger children. So again, just a brief review of cerebellar dysfunction, again, oversimplified, but we have concerns about motor, cognitive, and social-emotional things, and really highlighting the fact that these things are interrelated. It's really hard if we focus on just one aspect of it. We sometimes lose the full picture. And again, that's the nice thing about some of these measures is how do we get all the different pieces together so that we can look at it together. And really, this is what's hurt the development of this literature so far, particularly with the children, that when people have looked at what's been done to understand cognition in children with cerebellar disease, there's not a lot of consistency, and there's not a lot of sophistication that's been used in measurement of cognition with children in many of these articles. So Baldock had reviewed and looked at it, only 79% didn't have any standardized measure. So it was sort of an informal way of assessing it. In a more recent review of 74 articles on Chiari 1, again, the majority of those are just a gestalt. Is there an impression that the patient is improved, unchanged, or worsened? A small group looked at a particular sign or symptom, a headache or pain, and 30% used some sort of standardized scoring system. But again, the majority of that was the clinician impression, and very few had actually direct patient-reported outcomes. And not only that, but within that group too, that only about less than a third of them really looked at what's that impact? How does that affect the children or affect the families? So really we want to think about how to go forward. And that really requires multiple layers of work, including bedside work that can be done very briefly and very quickly, as well as more complicated and sophisticated things to look for more subtle differences. And as part of the Iceland Delphi results, one of the things that they mentioned was a recommendation about how to proceed with testing using both clinician ratings, parent input, and child direct assessment. And that's part of what I would propose as being an important thing, is really looking at these multiple different layers of how a child can be assessed and looked at. And also the need to follow children over time, that it's hard when we look at them at one point in time to really have the full picture. Children, particularly when they're young, development is not necessarily very smooth. It can be more stepwise, and depending on when you may assess them, you may not see the full picture. As they get older, we usually have longer periods of prediction for how they'll perform. I'm not going to go through these in a lot of detail. There's other ways that we clinicians can rate patients for outcomes, and there's some now, this movement from the more general to more disease-specific, really looking at what is unique to Chiari patients, what are the unique features that clinicians should focus on. And again, clinicians can rate this in a more standardized way, which makes it easier to compare objective outcomes across different conditions or different settings. There's also measures that clinicians can use for ataxia, and again, no one measure has everything that we want. So some of them are maybe the most reproducible, the one that's easiest to spread and disseminate so that everybody can learn to do it, but maybe doesn't include all the features you need, like ocular motor testing as well. We see the same thing when we look at sort of quality of life or the impact on the patient, that initially research looked at more general health-related quality of life measures, and we're slowly moving to looking at more specifics. What are things that are unique in quality of life to patients with Chiari, and recognizing that some of the global measures may not tap all the areas that you want to assess. So in particular, the Chiari Health Index for Pediatrics was recently developed. Again, it has both child and parent report. This is hard to read, but this is an example of it. It goes through pain, frequency and severity, other physical symptoms, as well as other functioning symptoms as well. So also what we get from kids and parents are we get symptom-specific things. Pain is often something that we ask children to rate, and it's always important to look at that pairing of the child's perspective, the parent's perspective, and the clinician perspective. You can get 3 different ratings sometimes depending on who's actually doing the rating. But these tend to be things that are fast and brief, like using the little visual analog scale. And there's also been a movement sort of to create more standardized measures of pain or cognition that can be used across different disease groups. Again, looking at, is this something specific or unique? And we also have measures, and the one thing that we've talked about the most is probably the measure of executive functioning that's been used by parents to describe children's cognitive performance. But there's also other clinical measures that parents can use to rate attention, mood, social, and adaptive skills. And inclusion of adaptive skills in kids is one of the things that I think we really do need to pay attention to. There's been a lot of research that's shown that executive dysfunction impacts adaptive skills, how much kids can do for themselves, how much assistance they need from parents. And when you look at parents' quality of life, that's usually the biggest driving factor. Parents have a lot harder time and a lot more burden when a child really struggles with adaptive functioning. Again, as Dr. Schaumann mentioned, we are looking at different positive symptoms and negative symptoms in different aspects of emotional functioning. And this is really now where we're going to get into the cognition, and this is where we start talking about the difference in development of what it looks like when we look at younger children. So particularly if we look at very young children 2 years and 6 months and younger, sort of what they were working at in the baby lab, there are not that many well-developed clinical measures to look at cognition. The Mullen scale and the Bailey scales of infant and toddler development are the main ones used, but they have much higher representation of motor functioning than the later measures of intelligence. So they don't tend to correlate as strongly as later measures of intelligence will going on. Most people look at the gold standard as sort of the Wechsler scales, but they can be cumbersome, they can be long to give. Even the latest version takes almost an hour for a neuropsychologist to administer. So a lot of times, again, in this model of how to manage the burden between all these things, we're looking at abbreviated versions where we may reduce it down to vocabulary, how many words can they define, and this type of matrix reasoning task where there's some sort of visual analog set up and a child has to pick a choice. We know from working with children, unlike adults, they're not very tolerant of non-interesting looking stimuli. If all of your stimuli are in black and white, particularly children under the age of 10, it's very difficult to get them to continue to engage in the task. So one of the things you see in younger children's measures is a lot more color and a lot more things that look like everyday objects. We also look at motor skills. Again, we can range from things that take a very long time but are very comprehensive in looking at motor skill development to things that are more focused and we have a clearer idea of what we're looking at. The groove pegs that's pictured there is one of the ones that tends to be our more sensitive measures of children's fine motor dexterity because it has both manipulation, how well can you turn those pegs to fit them into the slots, but also speed component, how quickly can they do that. The Beery is also a nice downward extension in comparison to the Ray figure because it's more structured. You can start at a younger age where you're just drawing vertical lines, horizontal lines, circles, and you can break it down into the planning or executive component. We take that out. There's a pathway already formed, and the child just has to draw within the pathway, to the visual component of it where they just have to match. They have to find the one that's the exact same figure. And again, the main thing that we look at with a lot of kids with different types of medical conditions are executive functions. They do seem to be the area that's most easily disrupted for children, and they're one of the hardest to assess in young children because they're changing and developing so rapidly. Many of these tasks are not normed well under the age of 8, so it becomes a challenge in the younger children to find measures that are going to work well. For example, the Stroop task works well if you've developed good reading skills, because it requires you to have a stronger sense of wanting to read the word than to pay attention to the color. But for when children are younger, they may not have such strongly developed reading skills, and that task may not have the same effect that we see with adults. The inferential reasoning and flexibility types of tasks, like the Wisconsin card sort, that's sort of an example of one where you're given a card and you have to decide where it belongs. You're given feedback about whether your answer is right or wrong, and you have to use that to figure out how to get the right answer. For many of our kids, we find those measures aren't as sensitive because there's no time component. They can take as long as they want to complete those tasks, but there's also a big frustration component with those tasks. The task will tell you, wrong, wrong, wrong. And even adults get discouraged, and you put a 6-year-old in front of it, and then they're done. That's the end of testing for the day. And some of the other tests, like even our verbal fluency tests, again, require children to be at a certain level cognitively. So we can usually do the category fluencies at a young age. Name a type of animal, name something you can eat or drink. But to have them generate words by a letter, words that begin with the letter F, words that begin with the letter S, that becomes very challenging for children under the age of 8. And when we look at sort of how do we measure attention, the other thing we want to think about is what level of attention. Some of our tasks are very basic vigilance. Just can you find something? Can you find a particular target? Then they start requiring increasing working demands. And then particularly as it extends over time, we can see greater dysfunction for kids with those measures being more sensitive but taking more time. So the tasks also sort of range from the briefest at the top to the longest at the bottom. And when we think about memory testing with children, we really, again, have to think about all the layers that go into most of our memory tests. Unlike a lot of the paradigms that are set up in research, our clinical measures of memory have different factors that are feeding into it. And all these tasks can have differences in organizations, demand on organization, demand on speed, or demand on motor. So for example, some of the visual memory tests, in an attempt to eliminate that motor demand, being able to draw, it's all multiple choice in picking, but all the pictures are shown in 2-second intervals, a very, very fast presentation time for a young child. So some children will struggle with that, not because they have a memory problem, they just can't process that information fast enough to stay up with that task. And the same thing when we do different types of verbal memory tasks. Children generally will do better with the story memory tasks when there's context and meaning embedded in it. Whereas the verbal learning tests, unrelated words, where there's a greater demand again on organization of that material, they tend to struggle more. Speech language, again, we looking at a wide range of things from articulation to naming skills to fluency. And again, these emerge at different ages. Difficulties with articulation can be really common when children are younger, but should start diminishing as they get older. And these were some of the other measures that have been alluded to earlier today, some of the measures of social-emotional functioning. We can have ratings and look at how people describe kids, but how do they really perceive and interpret social-emotional material? So for example, there's an example of the theory of mind card where they give a sort of a line drawing of a scenario and ask, how would that girl feel? Can you find the face that matches the emotion of how she would feel in that scenario? Next to it is the mind and the eyes task, where you get 4 different descriptors, and you have to decide what emotion you think those eyes are showing. And this is also a little hard to see. The false belief task is another one that's been used a lot in research on social-emotional development. So for example, there's this picture of Annie with her basket and a girl next to her with her box. Annie hides a marble that she wants to play with in her basket. The other girl is sitting there. Annie leaves the room. The other girl gets up, takes the marble out of her basket, hides it into her box. Annie comes back in and she wants to play with her marble, and where would she look for it? The child with autism usually doesn't step back and understand that she won't know things that happened when she was outside of the room, so she'll say it's in the box, whereas more typically developing children will understand she doesn't know that. She's still going to look in the basket because that's where she left it. And that's a pretty typical theory of mind task. One of the ways we've tried to deal with these issues of assessment with children, particularly with the limited resources sometimes for having long, lengthy neuropsych batteries, are using more computerized batteries. One of the benefits of some of these computerized batteries is their greater uniformity of tasks across age ranges. So with many of the clinical measures, for example, when a child turns 6, you're using a whole different set of measures than when they were 5. And there's sort of a discontinuity in the types of tasks they're doing. Many of these batteries are also designed to be quite brief, and they're good at looking at processing speed, sometimes more accurately than we can with more traditional measures, but there's also a price that's paid for that, and many of them have a lot less verbal things. You usually either have to have an examiner present to really do verbal tasks through the computerized battery, or they sort of try to do it through multiple choice, which changes the executive demands of those verbal tasks, would alter some of those capabilities. So there are things that can be done through these computerized batteries, but there's also limits. And you can also see this issue of age 8. A lot of the computerized batteries are not going to extend downward to those very young children because, again, these tasks really have to be modified so much for them to be able to engage with it. They're not going to be able to be modified for them. Some other folks in other disorders have really worked on how do we create a screening model? How can we screen kids and look at kids before and after to get a better sense of the prospective nature of diseases? And they've done that either with traditional measures, using some of these computerized batteries, and I'm going to talk more about the ones that I'm more familiar with, which is in childhood cancer. So we've used it from the very, very brief model that's used a lot, where we're using just parent report, using the brief and having parents rate on that, to moving to using just a few select neuropsych measures like digit span, which is a pretty sensitive measure generally, verbal fluency, grooved pegboard, trail making, something that doesn't take much more than 20 to 30 minutes to give. So that's usually a pretty reasonable amount of time to hold a child's attention or to perform some type of testing. And interestingly, again, parent ratings were not very well correlated with outcomes for those children. COG also has a battery that they've embedded to use with children with different types of brain tumors or other treatment conditions. Again, the idea is to try to reduce the traditional neuropsych battery into something very, very brief. And then if centers want to add on and do things in addition, they can, but this would be the core of what we'd be looking at. And again, there's some similarity to what we're talking about in terms of attention and executive measures, looking at digit span, looking at processing speed, looking at verbal learning, list learning, some measures of visual spatial like block design, as well as what should be more hold types of things like vocabulary, and then supplementing that again with parent report measures. The issues in computerized measures, as much as it seems attractive though, is there's a lot of downside in terms of hard drive and web interface. Here at the hospital, you can lose connection depending on where you are. There's always issues of where is that data being stored? Is privacy being protected? And that's an important consideration. Cultural effects, again, some people are more familiar or less familiar with computers. With children in general, we see they're more familiar, but again, there's some cultural groups that still don't have as much exposure. Age limits. Again, touchscreen works well with really young kids, but a lot of these neuropsych batteries have not been transformed to that for the very younger population. How much experience they have to understand this. Disability, so if they don't have good motor movements, can they operate it well? And again, there's not that much assessment of language, which can be a very important feature of what we're looking at. And there's also limited normative data. So if you don't have a control group that you're looking at, it's sometimes hard to understand that child's functioning. Is that really typical or not typical? So the things that you're often looking at when you are trying to put together a test battery is, are there norms that you can use? How reliable is the measure? Does it predict what you want to look at? Is it going to cover the age range you're interested in? And also the burden, both in terms of cost, availability, or how much time it's going to take. And just a reminder of the things that we also have to control, which makes research more complicated, is thinking about what are the other bits of information we need to gather so that we can assess that and make sure that's not contributing. When children don't sleep well, it affects their cognition in a pretty profound way. There's been a lot of research in schools lately looking at the impact of sleep on attention and executive processing. So that's something we really do need to consider. We also know that pain slows down processing speed and affects clearness of thinking. And so that's another thing that we need to think about as well. And also, when we look at kids with other disorders, we find that sometimes parent factors, what type of environment the child is raised in, has a pretty profound effect of how resilient a child is going to be or how vulnerable they might be to different deficits. So that's something else that we'll need to keep in mind. The thing to keep in mind too are your own resources. Who do you have to administer tests, to interpret tests? Where can you see kids? Bedside can be challenging for some of our neuropsych tests when we really do need distraction-free settings. Sometimes turning exam rooms for kids can be difficult. Do you have a chair that they can sit comfortably in? It's one thing if they're going to be sitting there for 10 or 15 minutes. If they're going to be sitting there for a couple of hours, it makes a big difference if their feet are hanging off the ground or not. I'm not going to go through this much. Again, we've talked a little bit about this, the access to different forms of technology or measures across different age ranges. And I just want to highlight this again because I think one of the things we really do need to think about when we assess kids is the different viewpoint we have. Everybody has a valid piece that they're contributing, but it's a slightly different viewpoint. There's some periods where we overlap, but there's also some uniqueness. And just to give an example, within Chiari, this is a study where, again, parents completed the brief, and they showed that children in general had more metacognitive problems, particularly working memory and initiation, although certain factors were not really related to those brief scores. And then when we look at other research with the brief, the thing to keep in mind is that the brief scores in other children were not related to how the children performed on tests. So parents rated them as having a working memory impairment, but they didn't show a working memory impairment on testing. Parents rated them as having impulse control problems, but they didn't show that on testing. And in a similar study, they did one with normal children in 1st and 2nd grade. They had both parents and teachers doing the brief ratings. Parents and teachers were highly correlated. There was a pretty strong relationship between what they each described, but it didn't translate that well into the children's performance on tests or in the classroom. So the only thing that had some significance was teacher rating. There was a little bit of a relationship with teacher rating to one of the variables, but not many of the others. And the parent ratings were not related to any of the outcome measures. Again, the other thing that can be difficult is following changes over time and this need for multiple versions or dealing with practice effects. Practice effects we know are particularly vulnerable within memory tasks. Whenever we have a memory task, it's important to think about how can we avoid having the child get better just because they've done the task before. Other tasks, such as reaction time, seems more preserved and less impacted by practice effects. And again, with young children, it's one of our struggles is they have lots of energy, limited attention. We have to engage them. Just telling them, do the task, isn't usually enough to get them to want to do it. Particularly children before they've entered school don't have that eager to please mindset yet, so that can be much more challenging. We try our best with little incentives and colorful stickers, but that's something else you really have to think about is, was the child really engaged and was their attention kept through that task? And in general, when we think about it clinically, these are the areas that we start being comfortable with the measures we have at different age points. So at birth, when children are first born, we can do sort of measures of general functioning. By age 1, we're pretty good at measuring motor development and social communication. By age 3, we're pretty good at assessing language skills as well as visual spatial skills. But you see, it's not until age 9 that we're really, really comfortable with executive skills and a clinical assessment. And that is a real challenge then when that's one of the areas that we're most concerned about. And this is just sort of, again, a sense of how those executive functions change over time, and there are these spurts where there's a real change in what a child can do and how much planning and organization they can have. And everybody thinks about this in the school model. When you go from elementary school to middle school, that's a huge jump in terms of, can you plan your different classes? Can you organize your materials? Can you keep track of your schedule? And children in elementary school usually can't do those things yet. And the last thing I'll just end with is just sort of, again, thinking even more forward. As we start really identifying these issues and thinking about these issues, really the next step is thinking about, well, how are we going to intervene? How are we going to improve the lives of kids with Chiari? Are there interventions that are going to be successful in remediating some of these cognitive weaknesses? And what is the impact on both family and schools in the context that they live in that we need to consider as well? So I'm going to end for there. Any questions?
People are talking about this, which is not a surprise, but yet you look at the difference how parents, rate things and versus. Have you ever looked at, or has anyone ever looked at, like, does it tell something if there's a big discrepancy, or has there ever been no discrepancy?
So I think,
does it tell anything?
Right. So one of the things that is most interesting is the time frame on what the behavior ratings are rated for. If a child is rating how they feel in that moment, that usually will correspond pretty well to how the parent rates them in that moment. So if the parent rates them as happy in that moment, the child will usually rate themselves as happy in that moment. But many of our measures are, how has the child been over the last week? How has the child been over the last month? And children don't always, one of the concerns is are children different because they don't have this ability to really integrate all of those experiences over time and collapse them into this single rating. And maybe parents and teachers, again, maybe that's why there's such correspondence between the parents and teachers, in what they're rating. But I think there's also things of children's experiences that are hard for even a parent to know. The more it's a behavioral piece, the stronger the associations are. The more it's an internal thing. Is the child sad? Is the child anxious? There's often a disconnect between the parent's rating and the child's rating, and it can be highly influenced by the parent's mental health status as well. So parents that are more anxious tend to rate their children as more anxious, and that becomes a complicating factor when we're looking at it.
On some of the aspects of the testing where a test should pick up something, but it doesn't, can you go into that? Is that the test itself, or what do you think that's about?
So I think that's always an interesting thing. I think, first of all, for executive functions, the issue is executive functions is so broad. Our tests are usually slivers of executive functioning, and so when it doesn't correspond, when a parent rates executive functioning, they're rating something different than what the test does. They're often rating, does my child misplace things? Does my child have a messy room? Is my child not prepared on time? The test is looking at, does that child control that impulse in that moment? They're really not even conceptually that similar. So I think there's a danger in the field of thinking, well, because they both say inhibit, they should be measuring the same thing. But when you look at the actual tasks and items, you can see that there's a disconnect between what they're assessing. And I think it's hard to recreate in test form some of what parents observe that drives parents' rating scales. Thank you.
Thank you.